Welcome to this live webinar. My name's Melanie Davies and I'm a Professor of Diabetes Medicine at the University of Leicester. This evening I'm joined by a live faculty who are an international faculty, and I'll ask them to introduce themselves. Firstly, Stuart.
Hello everyone, my name is Stuart Harris. I'm a professor at the Schulich School of Medicine and Dentistry at the University of Western Ontario in London, Ontario, Canada.
I'm Takashi Kadowaki from Japan, and I'm project professor of Department of Diabetes Metabolism, the University of Tokyo.
So welcome, Stuart, and welcome, Takashi. So this evening, our webinar has the following learning objectives. We'd like you to be able to demonstrate an increase in knowledge of the current and emerging landscape of GLP-1s in the context of pharmacodynamic profile, clinical use and current guidelines. We'll compare the efficacy and safety of GLP-1s and SGLT2s, and we hope that you'll be able to implement this newly acquired knowledge in clinical decision making, selecting the right treatment at the right time for the right patient in local healthcare settings. So this is an overview of our program. I'll give a brief overview of the GLP-1 landscape, and then we'll have some case discussions which we hope will illustrate the use of GLP-1s in different clinical settings. I'd like to point out that this is an accredited activity, accredited through ACME, and you'll be able to obtain your credits. Please make sure that you fill in the evaluation form to be able to do this. And also I'd like to remind you that we are live and that you can interact with us by using and sending through questions, which we will take the opportunity to discuss during the webinar. Again, please fill in your evaluation form at the end of the webinar so that you can receive your CME credits. I'd also like to acknowledge that this webinar is made possible by an independent educational grant from Novo Nordisk. Before we start and before we get into the main part of the webinar, I'd like to ask you the following two questions, really to give us a background of where we're starting from with your knowledge. So the first question is, if you could answer, I feel confident describing the most appropriate clinical use of current and emerging GLP-1s in the management of diabetes. Do you strongly agree, not sure, disagree, or strongly disagree? And secondly, question 2, I feel confident describing the safety and efficacy profiles of GLP-1s in different patient subgroups. Again, A is strongly agree, not sure, disagree, or strongly disagree. So if you could take time, please, to fill in those two pre-assessment questions, and then we can move on to our webinar. So I'd like to start with the presentation around looking at the landscape of GLP-1s and what we know about the GLP-1 landscape at the present time. So these are my disclosures, and I've worked with a number of companies developing GLP-1s in the context of clinical trials. In the next few minutes, what I'd like to do is give you an overview of GLP-1s, look at their role in cardiovascular and renal protection, and also in efficacy and weight loss, and then just summarise. So the first point to make is that GLP-1 has emerged as being very important in terms of the management of diabetes. And indeed, Dan Drucker described it as the conductor of the diabetes orchestra. So we know that GLP-1 lowers glucose, increases insulin, lowers glucagon, and increases gastric emptying. It also contributes to a lowering of body weight by both lowering food intake, increasing satiety and reducing hunger, and also has a number of effects on the cardiovascular system, directly reducing blood pressure and improving lipid profile, but also is thought to have an effect on reducing inflammation. And in this slide you can see the number of effects that it has across different organ systems. Therefore, restoring GLP-1 response has been a target for treatment, and there are two ways that we can do that, either by developing what we call the DPP-4 inhibitors, which are the oral incretin enhancers, and then we have the GLP-1 mimetics, or the GLP-1 agonists, which until now have been delivered by injectable therapy. The GLP-1 class is highly heterogeneous. So if we look at this slide here, you can see the molecular structure of the different GLP-1 analogues. So firstly, we have the exendin-based molecules, so exenatide and lixisenatide are examples of GLP-1s which are based on the exendin molecule. And you can see that there are orange and blue beads which make up the molecule, and about half of the molecule is homologous to human GLP-1 and half not. If we move to the next type, which are the acylated human GLP-1s, there we have a fatty acid side chain which protracts the action. So we have liraglutide, which is a daily injection, and we have the newer kid on the block, which is semaglutide, which is a weekly injection, but will also come to, because it's also available as an oral formulation. And then we have the large molecules, and that's dulaglutide, which is attached to IgG. And then we have albiglutide, which is attached to albumin, and these are both weekly GLP-1s. So here you can see the different molecules outlined, and the ones that I've highlighted are the weekly GLP-1s. Exenatide is available as a weekly administration, and then dulaglutide, which is available as a weekly administration starting at 0.75 and going up to 1.5 milligrams. Semaglutide, the starting dose is 0.25, titrated up to 0.5 and then 0.1 at monthly intervals, and then albiglutide. If we look at semaglutide, when we're developing GLP-1 agonists, we're looking to constantly improve their delivery and their efficacy. And you can see that semaglutide, compared to liraglutide, has improved albumin binding, it has better DPP-4 stability, it therefore has better access into the brain and is less lipophilic. And when I show you some of the data, those changes have resulted in a formulation that you can just give once a week now, but has also translated into greater efficacy in terms of glucose lowering and also greater weight loss. So as I mentioned, the latest innovation is the ability to be able to deliver semaglutide as an oral therapy, and this has been made possible by the co-formulation of semaglutide with an absorption enhancer, which is called SNAC, which is a small fatty acid derivative, and that promotes absorption across the gastric epithelium, and semaglutide is co-formulated with 300 milligrams of SNAC. So this slide shows the mechanism. You can see the small tablet sitting in the stomach. It's very clever because SNAC causes a small local increase in pH, which leads to higher solubility and protection from breakdown from proteolytic enzymes, which means that the absorption is strictly time and concentration dependent and is fully reversible. And about 1% of semaglutide can be absorbed orally through this mechanism. So what do we know about the GLP-1 class now in terms of cardiovascular outcome? And you can see in this slide how much the field has moved on. So we have more than 20 large cardiovascular outcome trials, including tens of thousands of patients across the globe. These are global trials and are relevant to patients across the world. And in the orange boxes, you can see the 8 trials that involve GLP-1 receptor analogues. Starting with lixisenatide, the ELIXIR study was the first to publish with the short-acting lixisenatide and really showed a neutral result, right up to the most recent study, which is Pioneer 6, which is with oral semaglutide. So if we look at these trials, there are 8 of them. 7 of them have now been published and fully disclosed. The FREEDOM study with the implantable lixisenatide has only been released in a press release but showed a neutral result. You can see they vary in the size. So the smallest study is Pioneer 6 with the oral semaglutide. The largest study at nearly 15,000 patients is with exenatide once weekly. In the bottom part of the figure, you can also see some differences. So, for example, in the REWIND trial, there was no lower limit of HbA1c. So we have a number of patients with an A1c below 7.2%. Also, the REWIND study is different to the others in that there was a much greater proportion of patients with multiple risk factors, or what we call subclinical disease, i.e. 70% of patients did not have established cardiovascular disease. This shows some of the differences in the baseline characteristics. So, for example, in the Liraglutide trial, semaglutide, and the Harmony studies, the A1C was quite high at 8.7 at baseline, whereas, as I said, in REWIND, where there was no lower limit for A1C, the mean A1C at starting was only 7.3%, so a little bit of difference in the A1C level, but otherwise the clinical characteristics at baseline were fairly similar. And as I made the point, if you look at the percentage of patients with established cardiovascular disease, it varied from 100% in the ELIXIR and the Harmony trials down to only 30% in the REWIND study, which is with dulaglutide. The other studies had around 70 to 80% of patients with established cardiovascular disease. Now, this is a little bit of a busy slide, but the point I want to make, and this is across the 7 trials where we have the results fully disclosed, you can see 3-point MACE at the top. So this is major adverse cardiovascular events, this composite endpoint. And you can see that in 4 of the trials, we see a positive result. We see a significant reduction in 3-point MACE. We see it with liraglutide, we see it with semaglutide when delivered subcutaneously, we see it with albiglutide in the Harmony trial, and also in dulaglutide. And these are all the human GLP-1 analogues. In Pioneer 6, the hazard ratio was definitely in the right direction at 0.79, but as I said to you, this was the smallest of the trials and it was underpowered. EXCEL just missed a significant endpoint, and ELIXIR really showed no significant reduction and no signal of a reduction in 3-point MACE. If we look at cardiovascular death, we can see a significant reduction with liraglutide, and although we shouldn't really look at the p-value and look at statistics, you can see that the hazard ratio for oral semaglutide was 0.49. So we get a more than 50% reduction in cardiovascular death with oral semaglutide. The other point I want to make is that heart failure was not increased but not reduced with these agents. And if you look at the composites of the different endpoints, you can see that with SUSTAIN there was a reduction in stroke, and we saw that in REWIND, and we see reductions in non-fatal MI in Harmony. But it's important really to look at the MACE rather than the individual endpoints. And this slide just summarises what I've already said. So I think we see, really with the human GLP-1 analogues, a broad evidence now for reducing MACE, which is, I think, very reassuring. The other important factor is that this reduction in rewind was in patients with established disease as well as those with subclinical disease or multiple risk factors. So in our consensus report, we talk in the ADA ESD consensus that was published in 2018, we now call out those patients with established ASCVD or heart failure or chronic kidney disease should be managed with a GLP-1 or an SGLT2. We also think about other compelling factors such as hypoglycemia, weight, and cost. So if we look at the presence of cardiovascular disease, we separate that into ASCVD or to heart failure or chronic kidney disease. So in patients with atherosclerotic cardiovascular disease, if that predominates, i.e. recent MI or stroke, then we should be thinking either about a GLP-1 or an SGLT2. However, if heart failure or chronic kidney disease predominates, we should preferably be using an SGLT2, and that's because of the data I show here. So this slide plots the heart failure risks across glucose-lowering agents, and you can see that TZDs increase the risk, DPP-4s, some of the DPP-4s increase the risk, but basal insulin, alpha-glucosidase inhibitors and GLP-1s are neutral on heart failure, but the SGLT2s at the top reduce heart failure. And indeed, there was a recent study called DAPA Heart Failure, which showed a reduction in cardiovascular death and heart failure hospitalization in patients with and without diabetes. So only 40% of patients in this study had diabetes, but the reduction in heart failure was consistent across both groups. The other thing that we know about the SGLT2s is that they significantly reduce chronic kidney disease and chronic kidney disease progression. We've seen that in a number of trials now, and we see their impact on important renal endpoints, including dialysis, transplantation, and acute kidney injury. Just a few comments about the GLP-1s and their impact on the kidney. We see a reduction in the composite endpoint for renal events with liraglutide and semaglutide, and Stuart will talk a little bit more about this, but it's largely explained by the impact on albuminuria. And we see the same with rewind, although there are some sensitivity analyses that Stuart will talk about, which give us some inclination about the effects of GLP-1 on the kidney. So they're good for the kidney, they reduce albuminuria, but thus far we haven't seen convincing reductions in renal events. So just to finish, just to talk about the important other factor, which is weight. So in the consensus, we talk about management of weight, the importance of medication, metabolic surgery, general advice. But when it comes to the glucose-lowering drugs, there are only two classes that lower weight. They are the GLP-1s and the SGLT2s, and there's heterogeneity across the GLP-1 class, which I'll come back to later when we talk about the cases. But if you look at the studies which have compared GLP-1s, this is a very busy slide, but if this is the exendin-based exenatide, either the long or the short-acting, where we see reductions in A1C, slightly greater for the longer-acting agent, less A1C reductions with the shorter-acting agents. We see good A1C reductions between liraglutide and dulaglutide, and liraglutide compared to most of the other GLP-1s. But if I take you right across the right-hand side, the dark blue is semaglutide, and semaglutide thus far has been shown to be the most powerful A1C reducing GLP-1, and also here you can see the weight, really significant weight reduction compared to all the other agents within the class. So to summarize, we're now in the time where we have positive cardiovascular outcome trials with the SGLT2s and the GLP-1s, which has prioritised their use in the guidelines. The GLP-1s do have heterogeneity across the class, and it's important to understand these differences when we think about managing our patients. And we're going to use the following case studies to highlight some of these issues. So I'm just going to end with a question. And what I'd like to ask you is, do you think that GLP-1RAs consistently reduce the risk of heart failure? And A is yes, B is no, and C is not sure. So if you could answer that question, that would be fantastic. Thank you. So now I'm going to move and ask Stuart to present the first case, which will hopefully illustrate some of the facts that I've given in the first presentation.
Thank you very much, Melanie. That was a terrific overview, and I'll try and build on some of those points and come back and reinforce some of the key issues. So the first case that I'd like to discuss is in a patient with established cardiovascular disease with type 2 diabetes. These are my disclosures. And I'll start with a question. So, and hopefully the audience can respond and choose. In your opinion, how important are the CVOT results to you when making therapeutic decisions for your patient? So A, very important. B, somewhat important. C, not at all important. Or D, depends on the patient. So if you could answer that, just so we can get a feel for what clinicians out there feel about the cardiovascular outcome trials. So it looks like the majority of our attendees today, Melanie, have been paying attention and agree that the cardiovascular outcome trials, in fact, do have an impact and are important in clinical decision making.
So just one point, though, because I think the previous question, when we were asking about heart failure, a number of the audience thought or were suggesting that the GLP-1s consistently reduce heart failure, and perhaps I wasn't so clear about that because I showed the data that actually they don't.
Right.
They don't increase heart failure, but we don't get the reductions in heart failure that we see with the SGLT2s. So perhaps we can discuss that a little bit more as your case goes through.
And I have some slides that we'll talk about the outcome. So let me start by introducing Mr. BB as our first case study. He was diagnosed with type 2 diabetes about 9 years ago. He recently quit smoking. He confides that he drinks 10 to 14 alcoholic drinks per week, and he's presenting to your clinic for routine follow-up for a post-ACS stent, which occurred 6 months ago. So a classic kind of cardiovascular disease background. Review of symptoms on today's clinical evaluation reveals only mild shortness of breath, no chest pain, but he does have, pre-existing risk factors, which include a BMI of 31. Blood pressure in today's clinical appointment was 140/83, heart rate of 62. He has an A1C at 8.4%, so not at target. His LDL is well controlled, however, at 1.7. But he's got some CKD emerging with a GFR of 76 and an ACR of 2.3. His current meds are listed here. You can see he's on 3 oral agents. He's on a combination tablet of sitagliptin, metformin, 50/850 milligrams twice a day. In addition, he's on gliclazide, 1 tablet at 60 milligrams. So, as I said, 3 oral agents. He's on a combination ACE hydrochlorothiazide diuretic at 4 and 12.5 milligrams. And he's on the fairly typical, in most regions around the world, fairly typical post-cardiac event type of medication profile, which includes a beta blocker. He's on metoprolol, 5 milligrams daily. He's on ASA, 81 milligrams, and clopidogrel, 75 milligrams daily, and appropriately on a statin, rosuvastatin at 10 milligrams daily. So that's his background therapy. So this leads me to my next question. So what glucose-lowering therapy would you choose next? Would it be an SGLT2 inhibitor? And these are the three common ones that are available in most markets around the world. B, choice for a basal insulin. C, a long-acting GLP-1, for example, semaglutide or dulaglutide. Or, as has been common in many regions of the world in years gone by, premixed insulin, twice a day. So let's see what our respondents, how they would manage this patient. So 75% would choose an SGLT2 inhibitor. Oh, sorry.
It's changing as we're speaking.
Yes, okay, I jumped the gun. It's a split. It's an even split between SGLT2 inhibitor and a long-acting GLP-1. So that's interesting. So that actually is a nice takeoff point for what I want to get into. So Melanie, you did a wonderful job overviewing the GLP-1 CVOT landscape. But just to put it in context, that cardiovascular disease is still the leading cause of death among people with diabetes. And you can see here in this graph that years of life lost in people with diabetes compared to those without diabetes, it's on average about 6.5 to 7 years. In the blue, it's non-vascular deaths, and the black is vascular deaths. But really important to point out on the right graph that this is a bigger problem in terms of vascular deaths in women compared to men in terms of cardiovascular disease and in patients with diabetes. And the mortality risk associated with diabetes, and there's in a large overview study of over 820,000 individuals, shows about a 2.3 increased risk for mortality with CV death if you've got diabetes, and all-cause mortality about a 1.8 increased risk if you have diabetes. I'm not going to go into detail about the recently completed CVOTs because Melanie's done this beautifully, but just again to emphasize the point that there's over 130,000 individuals that were included in these trials, and they range from 1.5 to 2 years up to a little over 6 years in the most recent Rewind trial. And they not only give us a lot of information about the primary question around cardiovascular disease, but around safety as well in individuals who've been exposed for a long period of time to GLP-1s. And that's been, I think, a huge benefit coming out of the FDA guidance mandated the CVOT trials. There's all of them have reported to date, except for one, which is just recently closed, the Virtus for erdagliflozin. But those findings should likely be coming out sometime early in the first quarter, second quarter of the new year. And as you mentioned, for the Freedom study, it's been reported in a press release, but not yet published. All the rest have really been published, and we have solid evidence. So I'm just going to highlight a couple of the trials. Just to get a little deeper dive into the findings that you alluded to. So we'll first look at the leader results, which of course was liraglutide versus placebo. And you can see that there was initially about a 1% A1C reduction, but this tapered off over time, over the 4 years of the trial, so that by the end of the trial it was only about a 0.4%. And I think most people would agree that it's not a glucose-lowering impact that has led to the benefit with the primary endpoint, which is in the right-hand forest plot, with the MACE primary endpoint being statistically superior, showing superiority at a statistical level after meeting the non-inferiority level. And the bottom graph really shows that a couple of important things, that you start to see the graph separate between placebo and liraglutide at about a year, roughly, which is very different from the SGLT2 trials that you alluded to, where you started to see separation early on, within months of initiation of the therapy. driven largely, as many of us believe, by the heart failure benefits, a reduction in heart failure. But this met the statistical significance hazard ratio of 0.87 for non-inferiority, and also met for superiority, as you alluded to. And this continued throughout the trial. As you see the graphs, the two lines begin to separate more and more over time. Looking at the SUSTAIN-6 results, so this is the looking at semaglutide once weekly versus placebo. Of note here is a high A1C at the onset of the trial, and quite a dramatic reduction in A1C, 1.7% reduction versus placebo for the 0.5 milligram dose of semaglutide arm, and 1.9% versus placebo. And this was maintained for the most part over the course of the trial. But at the end of the trial was 0.7% for semaglutide 0.5 milligrams, and 1% of semaglutide 1 milligram versus placebo. So a more substantive A1C reduction, but again, many believe that, again, it's not a glucose-lowering effect that led to the cardiovascular benefit, risk reduction benefits. And again, the primary endpoint was met. And you can see that in this case, none of the individual cardiovascular events met statistical significance, but the primary endpoint was met. And again, on the bottom graph, you can see that there's separation starting at about 24 to 32 weeks from randomization. This was continued. So that there was a fairly impressive 26% relative risk reduction in favor of the combined semaglutide arms, and it did meet superiority as well. Although, interesting, in the SUSTAIN-6, this was not pre-specified as an outcome, but it seemed to satisfy the reviewers at the New England Journal in terms of meeting superiority. And finally, we'll look at dulaglutide's effect on the cardiovascular composite. And again, the primary outcome was first occurrence of non-fatal MI, non-fatal stroke, CV death, MACE, in other words. And here again, you see very similar kinds of findings that about within 1 to 1.5 years, you see a separation of the curve favoring dulaglutide versus placebo, and a hazard ratio of 0.88, which met its primary outcome of benefit for MACE, favoring dulaglutide versus placebo. Have these results impacted guidelines around the world? Yes, they have. And of course, Melanie, who's leading the charge for updating the ADA ESD guidelines, and again, hopefully there'll be a new update coming soon. They've definitely impacted guidelines around the world. The question is, has that translated to a change in practice? And in part why we're having this conversation today. So let's go back to our case, Mr. BB. And here's what we decided to do in clinic. We decided to start a GLP-1 analog, once weekly in this case, the semaglutide. He went on the usual approach of the low dose, 0.25 milligrams subcutaneous for 4 weeks, which was increased to 0.5 milligrams weekly. With in many regions around the world, they might see this individual at about 3 months. Certainly that's what we do in our practice. And at the same time, sitagliptin, of course, was discontinued. You don't need the oral incretin anymore. And the possibility of being able to further reduce, have a pill-sparing strategy, and discontinue his gliclazide, depending on his response to semaglutide. So we chose this in discussion with the patient as the option because he was impressed with the evidence around CVOT benefits in individuals like himself who have pre-existing cardiovascular disease, the very impressive efficacy to help get his A1C down towards target. He really liked the weight loss benefits, and as we saw, his BMI was elevated at 31. And there is also the discussion about maximizing the benefits of all of these above issues, going up to 1 milligram weekly to get the most benefit out of the therapy. So 6 months later, in fact, he is feeling very well. Reports that he's lost 5.5 kilograms and continuing to lose weight. Certainly in our experience in Canada, we see that this weight loss really kind of rejuvenates individuals' interest in undertaking lifestyle again to further to achieve further weight loss, and that's certainly been the case with Mr. BB. And current glycemia-lowering meds now include, he did go up to the semaglutide 1 milligram. He's only on metformin 850 milligrams twice a day. He's now very close to target. His A1C is 7.1%, and his blood pressure is pretty well at target. And there's been no change in his renal function and no exacerbation of his albumin-to-creatinine ratio.
So thanks, Stuart. I mean, that's a great case, and it's a case that clinical dilemma of what we should add, and that the audience was fairly split, really. So we've got a couple of questions. So the first question, and to remind you, please, to keep sending in your question. The first question was about risk of hypoglycemia and prolonged QT with GLP-1s, I assume. I mean, we know that there's a very low risk of hypoglycemia. We know that there's an increase in heart rate, but there's no suggestion from the studies with the long-acting GLP-1s that there's an increase in QT interval. And either of you have a comment on that?
Well, certainly one of the advantages in choosing the GLP-1s is the very low risk of hypoglycemia compared to the other options that we presented at the beginning of the discussion of insulin. And in this case, this individual is able to discontinue his sulfonylurea as well. So I think it's one of the added bonuses is that he has a very low risk of hypoglycememia.
Yeah, so it's really the SUs, and if there was concomitant insulin which drives the risk of hypoglycemia, is not the GLP-1s or indeed the SGLT2s.
Absolutely.
There's another question about age, about what age you would stop SGLT2s or GLP-1s. Takashi, do you want to comment on that?
I don't think we will stop SGLT2 inhibitors or GLP-1 receptor agonists just based upon the age.
Absolutely.
But, you know, older age may be associated with the reduced renal function such as EGFR. And if EGFR is below 30, then the current guideline says SGLT2 inhibitors may not be may not have glucose lowering effect. So we may think about stopping the SGLT2 inhibitors when renal function becomes very low.
Yeah, and I think the reassuring thing about semaglutide and dulaglutide, and indeed liraglutide, is that there's good evidence now in renally impaired patients.
Right.
We can use them really right down to an EGFR of around 15, I think, the current. So that's reassuring in terms of renal indication. There was some data, I think, from Declare in an older age group that was presented at the IDF meeting recently that showed that the side effect profile was similar in the older patients, the younger patients, and no signal. So I think we're getting more data in older patients, but as you say, we need to be careful. There's a question, and I think this is a really good question. In this particular case, why did you prefer the GLP-1 over the SGLT2? I think it is a reasonably close call, and as you said, sometimes it's down to the patient preference. Some people would, I think the difference with the long-acting GLP-1s is the injection is just so much easier now. Before it was, and some patients, when they see how easy it is, actually prefer an injection once a week than a tablet every day. I don't know if you want to comment on that.
Yeah, well, I think in addition, I mean, his A1C was, about 1.5% above target. chances of getting to target on an SGLT2 where you might expect about a 1% lowering of A1C versus 1.5 to 1.8 on a max dose of the once weekly semaglutide. So your chances of getting to target were much better at the same time of removing some of the oral agents that he was on. And he was really impressed with the superiority of the weight reduction option, which in the once weekly GLP-1s is higher. There's greater weight loss than compared to the SGLT2s.
Yeah. So the questions are flooding in now. So some quick answers to some of these. So risk of thyroid cancer. I think we're clear now that that's not a risk. So it was a theoretical issue early with the GLP-1s. It's really not been seen in clinical practice. There's been quite a lot of safety registries looking and now long-term follow-up, and I think
I don't think it's a concern any longer.
Yeah, so it's really.
As I mentioned, that one of the big advantages of the CVOTs was the safety data, and thyroid was one of the things that did not emerge as an issue.
So Stuart, we're going to go to your second case and go through that briefly, because there's lots of questions that I think we can pick up as we go through that, if that's okay.
Great. Well, we've kind of started to get into some of the discussion around renal impairment. So let me introduce another case. So the title of this presentation is Delaying Progression of Renal Impairment in People with Type 2 Diabetes and Chronic Kidney Disease, with a focus on GLP-1s. Same disclosures. So let me introduce Mrs. ARL. So this is a 72-year-old retired teacher. She was diagnosed with type 2 diabetes about 15 years ago. She presents for routine follow-up in your clinic. A review of symptoms only reveals some numbness complaints in both of her feet, may be reflective of neuropathy in her long-standing type 2 diabetes. She has no retinopathy, and she does not have a history of cardiovascular disease. Her BMI is elevated at 32. Her blood pressure is slightly elevated at 140 over 84 millimeters of mercury. She's not well controlled. Her A1C is at 8.3%. Her LDL is close to target at 2.1, but of note, and this is probably reflective of her long-standing history of type 2 diabetes, she has quite substantial renal impairment. Her GFR is down to 29, and she's got some microalbuminuria with an ACR of 12.7. So you see this in people who've had long-standing type 2 diabetes. Her current medications are the following. She's on linagliptin, 5 milligrams daily. She's also on a combination ACE diuretic of perindopril hydrochlorothiazide, 4/12.5 milligrams daily. She's on amlodipine once a day. She's on a statin, a atorvastatin, 20 milligrams. And fortunately for her, she's not on many other medications, just a little bit of asthma that she treats with a Ventolin inhaler, PRN. So we'll start off with a question again. What glucose-lowering therapy would you choose next for Mrs. ARL? Would it be a glyburide, 5 milligrams twice a day? B, an SGLT2 inhibitor? C, a basal insulin, which certainly historically would be one of the therapies we would go to in this kind of scenario. D, a long-acting GLP-1 such as semaglutide or dulaglutide. Or E, MDI, basal bolus therapy. So be interested to see how people vote on this one.
So we're getting a bit of a split. So nobody wants the, at the moment anyway, nobody likes the sulfonylureas or the basal bolus insulin, which I think is actually quite reassuring.
Yes, I would agree.
We've got actually quite a few people going to the long-acting GLP-1, and I think we'd mentioned the renal indication. If the SGLT2, if the EGFR was, I know in Canada you can go down to 30 now, so if that EGFR was 35, would your answer have been the same? Because I think the SGLT2s look pretty impressive in terms of preventing long-term progression.
I think certainly after Credence, there's no question around the protective benefits, especially in someone like this, like this case. However, even though and we have the indications, as you mentioned, in Canada, you can use it for renal protection down to a GFR of 30. There is no clinical advantage in that, even in the GFR that you described at 35. There's no A1C, there's no glucose-lowering benefit.
But there is the benefit in protection
renal
of the
protection.
kidney.
And had she had maybe a slightly higher GFR, we might have considered that in addition to another agent, which the audience has chosen, the majority have chosen a GLP-1.
Yeah, so I think the SGLT2 in this situation, there's nowhere in the world that currently license it below 30.
That's
I mean,
right.
there are studies ongoing.
Right.
A couple of studies, DAPA kidney and EMPA
kidney,
where they're going down to EGFRs. I think in EMPA kidney down to 20, but we don't have the data.
We will have the evidence in near future.
Yeah, looking forward to that.
Yeah.
So you know, again, not to overplay the wealth of data that we've had with the CVOT trials, it's important to point out that many of these trials, in fact, also had pre-specified renal outcomes as secondary outcomes. And just highlighting many of them here that have been completed, or the 6 to 8 trials that are ongoing that will also include renal outcomes. So I think that the evidence is growing around the benefits for the incretin class, and we're looking forward to getting more evidence beyond credence in the coming years in these CVO2 trials. So just again I have the opportunity to get into a little more detail around a design of some trials. Again, I'm showing a couple of the published studies in the once daily Liraglutide or LEADER cardiovascular outcome trial, which compared Liraglutide at 1.8 milligrams versus placebo. We know that the primary outcome. SUSTAIN-6 had 2 doses of semaglutide versus 2 placebo doses that they were compared to. Again, similar types of trial design. But important to note that these also had pre-specified renal outcomes. And I'm just going to take a minute here to highlight what some of these findings were. So in the LEADER study, the time to first nephropathy event, which was defined as macroalbuminuria, doubling of serum creatinine, end-stage renal disease or renal death, did show a fairly impressive risk reduction of 22%, favoring liraglutide over placebo. And again, you started to see the separation of the curves at about a year's time, which continued and grew over the duration of the trial. So clear evidence, I think, from the LEADER study around reducing time to first nephropathy event. In the SUSTAIN-6, they had a composite renal outcome that they had pre-specified, which included macroalbuminuria, doubling of serum creatinine, RRT, and renal death, RRT being renal replacement therapy, and renal death. And here it was even more impressive in terms of the composite renal outcome benefits, favoring the once-weekly GLP-1 semaglutide, with a 36% risk reduction, relative risk reduction, favoring semaglutide over placebo. And again, you start to see the separation of the curves at about a year and a half, and very impressive, I think, renal protection benefits over the length of the trial. In the REWIND study, and you alluded to this in your opening presentation, Melanie, there was sustained GFR decline, but they broke it up in the sensitivity analysis looking at different GFRs decline, and you can see that the worse off the GFR was, the more benefit there was in decline. So looking down in the sensitivity analyses of a decline from 30% to 40% and 50% from time of randomization. So real good evidence showing in the sensitivity analyses anyways, benefits of a once-weekly GLP-1 here. So coming back to our case, Mrs ARL, what should you choose? Well, happy to see that the respondents agree that glyburide would be a poor choice due to risk of hypoglycemia, especially with the GFR that she has, and the slow clearance that glyburide would have in her kidneys. An SGLT2 inhibitor, as we discussed, would not be the choice here because it would not meet the criteria in countries around the world and will not improve glucose control at this lower GFR. So you'll get the benefits around renal protection, but not around glucose lowering. A basal insulin is an option and a good option, but patients such as Mrs ARL was reluctant due to the concerns about daily injections, insulin, and the weight gain that she might expect to experience with insulin. And I think it really highlights the change in ADA-ESD guidelines over the last few years with now preference for a GLP-1 option over insulin. It's in a case such as this, in patients like this. And then the long-acting GLP-1 was her preferred choice in our conversation because of the benefits of the slowing down renal decline, the excellent efficacy regardless of the GFR, and I think that's really important to point out that it didn't matter what the GFR was in these trials, you still saw the same kind of efficacy in glucose lowering, the opportunity for weight reduction, the low risk of hypoglycemias, and some blood pressure benefit, which is also renal protective. A basal bolus therapy is still an option, but of course, with complexity required, increasing risk of hypoglycemia, weight gain, and particularly as a lot of these patients are managed in primary care, not an ideal type of therapy choice for many primary care physicians, as it's very complicated for many primary care practitioners to implement. So in summary, just to wrap up, that long-acting GLP-1s have demonstrated from the evidence to slow the decline in GFR in individuals with type 2 diabetes with CKD stages of 3 and 4, particularly if albuminuria, as you pointed out, is elevated. The beneficial effects of long-acting GLP-1RAs on the kidney appear to be independent, at least in part, of the improvement in A1C. They are safe in patients with CKD, and that's why we've seen a change in the labels in many markets around the world down to 30, as we have and even 15 in some countries. And then the long-acting GLP-1RAs also reduce cardiovascular outcomes, particularly in patients with type 2 diabetes and CKD. So lots of reasons why these would be good options to consider in a case such as Mrs. ARL.
So thanks, Stuart. So lots of questions about safety, and I think it's important to look at the safety profile of the GLP-1 class. As we've already said, there was concerns about the thyroid. I think now, after more than a decade of GLP-1s, we're really reassured that that's not an issue. Takashi, a question come up about pancreatic cancer. So your comment on that?
Okay, according to the publications, I don't think pancreatic cancer is not an issue at this moment. However, I think pancreatitis, may be an issue when the patients have a previous history of pancreatitis.
So I think, as Stuart said, the good thing about all of these long-term cardiovascular outcome studies with both DPP-4s, which are incretin-based, and GLP-1s, we do see a small absolute increase in pancreatitis. It's a small increase. The pancreatic cancer story, I think, has gone away and has been put to bed, and really there isn't a concern about pancreatic cancer, which was raised by some experimental work a while ago, but really hasn't been seen in the clinical trials.
And just to add that, it's interesting to see that cholelithiasis has come out in these trials as a real issue. So maybe there's some linkage there with the
and I think that's often relates to the weight loss that we see, because you see increase in gallstones. So we see that. I think in anybody with renal impairment, we need to be careful about hydration and nausea and vomiting. The GLP-1s are associated with gastric intolerability, which is why the titration is important. There'll be some patients that won't tolerate them, but largely if we titrate slowly, they do fine. There's a question about retinopathy. So this was seen in SUSTAIN 6. Do you want to comment on the retinopathy?
Yeah, so, you know, it's one of the only trials that has really demonstrated the retinopathy, although they really investigated retinopathy quite aggressively in the trial, different than some of the other trials. And we always run into issues where you're trying to compare across trials because the designs are different, the patient profiles are different. There was a signal for retinopathy in the patients who received semaglutide. The prevailing belief is that this could be related to the rapid reduction in A1C. You remember the graph I showed how fast and how dramatic the A1C reduction was in patients who received semaglutide. Similar, and we know from other trials from years gone by, such as DCCT, et cetera, that when you have a very rapid decline in someone who might have some background retinopathy, that can exaggerate or exacerbate the retinopathy. So that could be the reason why there was a signal for retinopathy.
So there's a study ongoing called FOCUS, which is looking at this in some detail. I think other analysis, particularly from the oral semaglutide program, hasn't shown any signal for retinopathy. But I think if you had somebody with untreated pre-proliferative retinopathy, you'd want to treat that before you put them on something that was going to lower their glucose rapidly.
And if you talk to ophthalmologists, they'll say, please get their sugars down if they've got some retinopathy.
So the other question was around managing GI side effects, and I think we talked about that a little bit, about the titration, making sure that you up-titrate slowly. I think there's also an educational point. I think many patients, if we explain to them that they will feel fuller sooner, because for some patient feeling full is another person's nausea. So, Takashi, any tips?
If we tell patients that you may become accustomed to that. That may
so it usually settles with time. So often I think good education and explanation of how the drugs work, slower titration and down titrating until people tolerate. There will be some patients that won't be able to tolerate
we definitely see
the agent, but it's a small proportion, and usually we can get round things. So I think if you can keep sending your questions in, lots of great questions, and I've still some more that we answer as we go through, but we're going to move now to our third case, which I'll quickly talk about, which is around patient preference, and I don't like the term adherence, but it's still used in the literature. But anyway, these are my disclosures. I suppose just some points. So this is from the ADA-ESD consensus, which talks around putting patients at the centre of their care. And this is our figure from that, which is this decision cycle, where I want to make the point that we're moving away from lowering glucose for the sake of lowering glucose, because the reason we target an optimal A1C is to reduce complications, particularly microvascular complications. But we now have agents that reduce complications independent of A1C. So our goal should be to optimize quality of life and to prevent complications. So this is the case. This is a housewife who's in her 60s, who's had type 2 diabetes, not for so long, but is depressed, struggles to remember her medication, mainly because she's really very depressed, and motivation and prioritizing her medication is really not a priority. She's largely depressed because of her weight. You can see her BMI is over 32. Her A1C is above target at 8.1. She's got good renal function, and you can see the rest of her lipid profile there. She's on metformin and a sulfonylurea and atorvastatin for her lipid profile, and her blood pressure is reasonable. So when we're faced with somebody like this, I think just to sort of go through where we need to start, and I think often assessing key characteristics, particularly around comorbidity. So this lady doesn't have atherosclerotic cardiovascular disease or chronic kidney disease or heart failure, but she is depressed, and I think often the wider issues, the cultural and socioeconomic context, motivation, depression, are other things that we really need to be aware of when we're talking to patients and thinking about priorities. Also considering risk factors, because if we just go and talk straight around the A1C and lowering the A1C, that really isn't this lady's priority. She is concerned about her weight. We need to try and help her with regimes that are going to make life a little bit more simple for her. And we need to think about the access that she has to medicines and the availability of medicines. And we're talking in this new consensus, shared decision making has been around for a long time. It's got a good evidence base, but really seeking patient's preference, really finding out what is important to the person with diabetes is really critical. And this ongoing support, not just around glucose, but also around emotional well-being, treating her depression, and checking the tolerability and acceptability of any medicines that we choose to use. And I just show this slide because I think it's really relevant internationally. There's been a lot of discussion at recent meetings about the use of our language, and there's been some excellent work led by colleagues in Australia and other parts of the world about how we use language when we're talking about people with diabetes, particularly people with type 2 diabetes, where often we may use language that makes people feel guilty or is in some ways threatening, but we need to be making sure that we use language that is respectful, inclusive, and actually makes people feel better about themselves.
Non-judgmental.
So bearing all of that in mind, the other thing that we need to do is to not collude with patients. Healthcare professionals are very slow often to start treatment and to advance treatment, and that's another area that we need to address. So if we look at this algorithm, actually this lady doesn't have established ASCVD or chronic kidney disease, but what she does have from her perspective is a compelling need to reduce her weight. And we want to try and improve her glycemic control, and as I've said before, really there's only two classes of drugs that do that. The SGLT2 inhibitors are effective weight loss, cause effective weight loss of around 3 to 3%, 3 to 4%. The GLP-1s also have good efficacy for weight loss, but there's huge heterogeneity across the class. And if I show you this slide again, just to remind you, really the best data for weight is with semaglutide compared to all the other GLP-1s. And if we look at the two classes, here are the GLP-1s versus the SGLT2s, actually not so many trials. There's only been a couple of studies. In Duration 8, there wasn't really even a statistical analysis between the two, but you can see in terms of A1C, exenatide weekly slightly better than DAPA, but as I said, there was no stats done on the single arms. Pioneer 2, which is the oral semaglutide, about 0.5% better than empagliflozin, and semaglutide about 0.5% better than Cana. But if we look at the weight as well, in fact, it shows you the differences with the GLP-1s, because the exenatide DAPA comparison, there was actually numerically greater weight loss with DAPA than the GLP-1, whereas in Pioneer 2 and in Sustain, we see about, it's about a kilogram difference with semaglutide compared to canagliflozin. So the next question then is, what would you add to her therapy to help maximise weight loss? These are not obviously weight-losing drugs, but these are drugs to manage her diabetes, but also to address this concern that she has around her weight. So if I can ask you to answer now that question. So in terms of most people think, oh, it's changing now a little bit. So I think if we look at the consensus, really, there's only two classes added to metformin that would be weight losing, which are the GLP-1s and the SGLT2s. There's still a few people using a TZD, which actually has more weight gain than SUs, actually. Nobody's using the DPP-4s, which are weight neutral, and a few people using the SGLT2s, which would be perfectly reasonable in this situation, and others using a GLP-1. Second question, if you were to choose a GLP-1, what factors would influence your choice? Would it be how often you need to give the injection, whether there's an oral versus an injection, the A1C lowering, the degree of weight loss, or any other issues? So if you could just answer that question too. Okay, so most of you are influenced by the degree of weight loss, but others by the A1C lowering. Not so many around the frequency of administration. I think, I think that actually the long-acting agents are a significant advantage in this regard, both in terms of the ease of giving the injection, and certainly when I'm talking to patients, the fact that you can have something once a week rather than once a day is a big plus. But obviously a number of factors that we can take into account when we think about this. So a number of questions that have come through in terms of this. So one question is, in which conditions would you never use a GLP-1? Takashi, where would you never use a GLP-1? Stuart, any thoughts?
Okay, I don't think I will use a GLP-1 receptor agonist in very thin and sarcopenic and frail patients.
Right.
Okay, good.
And I think this would be reflective in many markets around the world. GLP-1s continue to be quite expensive.
Yeah.
So if there's not good access to coverage and supporting them, that would be another obvious reason not to choose them.
Yeah, and in some patients, I think with gastroparesis, if you're concerned with GI effects, but I think the other old questions in the past around pancreatic cancer and thyroid really have been put to bed, so they're no longer concerns. The other, and this sort of follows on really in terms of, are there special concerns in elderly patients? And I suppose it came back to your comment, Takashi, about it's not the age, it's the other comorbidities. And I think there are now guidelines, particularly the Japanese guidelines, talk about frailty.
Oh, exactly. I don't think all the elderly patients, sarcopenic and have frailty. But if elderly patients have, sarcopenia and frailty and very thin, I don't think GLP-1 receptor agonist, which may reduce an appetite, may not be the best choice to use.
Absolutely. Yeah. Okay, so I think that sums up nicely the types of patients. There's one question about, do you think that GLP-1s will be the treatment choice first line before metformin in those diagnosed with cardiovascular disease and diabetes? Now, some people may be aware of the European Society of Cardiology guidelines, which has suggested that in newly diagnosed patients, there's lots of controversy about that suggestion, and certainly in the ADA-ESD and many other guidelines, metformin has remained first line, mainly because it's very cheap, it's accessible across the world, and in all the studies we've shown you, virtually, 80% of patients were on a background of metformin. I think the only downside is that we're suggesting, or we have suggested, that you have to wait until the A1C gets to target or above target until you add. So I think that will change moving forward to make it easier to add these agents.
Right, I would agree. But the evidence is quite compelling for GLP-1s, I think, in terms of the cardiovascular benefit in patients who have had an event.
Okay, so I think we're going to move, Takashi, to your final presentation. We've still got some questions coming in that we can pick up as we go through that.
So I would like to discuss weight management by GLP-1 receptor agonist. And this is my COI disclosure. So this case is a 60-year-old male, and he weighed over 100 kilograms, 20 years of age. And I will add one more information here. His height is 171 centimeters. He was diagnosed with type 2 diabetes and started medication at 43 years of age. He became obese, and he was hospitalized and therefore lost weight from 141 kilograms to 133 kilograms when he was 50 years old. However, he then regained weight from 133 kilograms to 141 kilograms because of overeating. And he wanted to get bariatric surgery, and he did get bariatric surgery, but before he received bariatric surgery, we thought that he should reduce his weight because in order for the operation is very safe. And in the treatment of diabetes, GLP-1 receptor agonist was administered. And before that, SGLT inhibitor, metformin, thiazolidine, and insulin were used. I will show it more clearly later. And lifestyle, smoking, and overeating, and drinking. Okay. So he originally used thiazolidine and metformin and insulin, then SGLT inhibitors. And as when he started to use insulin, his overeating was accelerated, and he became obese from 130 kilograms to 141 kilograms. Okay. But he wanted to receive bariatric surgery, but we wanted to reduce his body weight to some extent in order for the bariatric surgery to be safer. We then, in the outpatient clinic, started GLP-1 receptor agonist, in this case liraglutide, 0.9 milligram per day. At that time, the maximal dosage allowed in Japan. Now, we have recently become to use 1.8 milligram per day for type 2 diabetes. But anyway, changing insulin to GLP-1 receptor agonist had a weight-reducing effect by around 7 kilograms. Okay. Then he admitted to the hospital, and then after further weight reduction, he managed to receive bariatric surgery. And after bariatric surgery, weight went down and down to the current data, 96 kilogram body mass index 32.6. How about hemoglobin A1C? Hemoglobin A1C was not super high, but around or just below 7%. We changed the insulin to GLP-1 receptor agonist, not for glucose lowering purposes, but for body weight management purposes. And as I indicated, GLP-1 receptor agonist usage was associated with a body weight reduction. After bariatric surgery, the hemoglobin A1C became very good, and current data is 6.0%. The case summary: an obese diabetic patient who had difficulty in weight management because of overeating and drinking. And we then switched the treatment from insulin to a GLP-1 receptor agonist, which supported weight reduction and glucose control. Bariatric surgery reduced body weight by 30 kilograms, and only metformin was needed to maintain glucose control. And this is the data of the clinical trial of the liraglutide 0.9 milligram per day, a phase 3 trial, indicated change in hemoglobin A1C. And liraglutide 0.9 milligram was sufficient to get very good glucose lowering effect as compared to placebo in the context of combination with sulfonylurea, and also in the context of combination with insulin. Moreover, liraglutide had more glucose lowering effect even as compared to glibenclamide or to oral anti-diabetic agents. As compared to glibenclamide, liraglutide 0.9 milligram had a weight reducing effect. However, as compared to placebo, this dosage of 0.9 milligram did not have a clear body weight reducing effect. Probably this 0.9 milligram per day may be sufficient for glucose lowering purpose, but not sufficient for weight reducing purpose. And in fact, liraglutide 1.8 milligram per day data showed not only glucose lowering effect, but also weight reducing effect. However, even 0.9 milligram liraglutide sometimes reduces body weight, but in particular in obese patients. And I wanted to show this slide because Asian patients, such as Japanese patients, are known to be very sensitive to incretin-induced glucose lowering effect as compared to Western patients. And I have a relatively easy question at the end of the day: in which of the below anti-diabetic medications are useful for body weight management in obese patients with diabetes? Insulin, GLP-1RA, DPP-4 inhibitors, SGLT2 inhibitors, thiazolidinediones, and metformin.
And I think you can have more than one answer.
Yeah, more than one answer.
So if we could,
a clear winner.
Yeah, so I think in terms of useful for body weight, certainly GLP-1s, but as we've said, there's really quite marked differences across the class. You see very little with lixisenatide and more with, as we go through, dulaglutide, liraglutide, semaglutide. The SGLT2s are useful, and they are useful for body weight management. And some people would suggest metformin has a small effect, neutral if slightly weight losing in some studies.
I think in the clinical trial of the SGLT2 inhibitors in Japanese patients clearly indicated body weight reducing effects. And I think metformin sometimes has body weight reducing effect, but it depends on the patients.
Yeah. So some questions. So one question about, and I think you mentioned liraglutide in weight loss. Is there any place for semaglutide for treatment for obesity? So you showed a really nice case of bariatric surgery. We know that bariatric surgery is by far the most effective at weight loss, but it's not available to everybody.
Right.
And what we're trying to do is get pharmacological therapies as well as diet and lifestyle that can get you close to that. So semaglutide in diabetes, I showed you the weight loss that we're getting, sort of 6 to 8 kilograms. There's a phase 2 program of the weekly 2.4 milligrams where we're getting nearly 15% weight loss, and there's a large phase 3 program now looking at semaglutide in obesity, a number of trials, including a cardiovascular outcome trial. So we'll certainly, over the next couple of years, see that data. And we already have liraglutide, for example, licensed as a weight loss medication.
Okay.
What about...
I also agree that semaglutide may be more body weight reducing. But semaglutide data in the Japanese clinical trial also indicated that semaglutide has a very marked both glucose lowering effect and body weight reducing effect.
Yeah.
But we have to wait a little bit more.
Yeah, for the data. Yeah, absolutely.
For the final approval.
Oh, okay, so it's still going through approval.
Yeah.
Okay.
But we, most likely, we will get the approval soon.
Yeah. So this is well established in Europe and in Canada and the US, and I think in the US already have the oral semaglutide, and that will be coming, I think, to us. What about, you showed the evidence for a GLP-1 prior to surgery where you get some weight loss. What about, because over time those patients regain weight, what about post-bariatric surgery? Is there a role for GLP-1s?
Oh, yes. I think GLP-1 receptor agonists may have a supportive role both for safe bariatric surgery by appropriate weight reduction before bariatric surgery. And also, as Melanie pointed out, GLP-1 receptor agonist should be quite useful to protect from rebound.
Okay.
Yeah.
So some other questions. What about combining GLP-1s with SGLT2s? Will we see more MACE reduction? Stuart, what's your view about that?
Well, we don't have the trial evidence to support that, but I can tell you it's becoming more common practice. Certainly in our clinic, we do this a lot. We just have on a hunch that why not offer the maximum protection for future events. And of course, many of these patients have concomitant renal issues, so adding an SGLT2 would also have advantages to help for renal protection. So it's a very quickly moving landscape, and guidelines aren't there yet, but
so very few studies looking at the long term, but the benefits sort of complement each other. In practice, we are using this. And one of the questions is, if we do combine, what are the adverse effects that we need to be careful of?
I think excess, loss of body weight in again the elderly patients.
So in the studies I show, I didn't show them actually, but there are some studies combining GLP-1s on a background of SGLT2s showing added weight loss, low risk of hypos, and actually quite good tolerability. So, but as you point out, the side effects of the single agents we need to be careful.
And also, I agree with Melanie and Stuart that both actually may reduce the cardiovascular events, but in a different way. GLP-1 receptor agonist appears to slow down the atherosclerosis process itself. However, SGLT2 inhibitors rather actually has a direct protective effect of heart and kidney rather than slowing down the atherosclerosis process itself. So they are kind of complementary and additive.
And that may be undiagnosed heart failure that some of these individuals may have.
So still lots of questions to get through. So an interesting question about high triglycerides, and I suppose we should mention if somebody has a very high triglycerides and at risk of pancreatitis, you would want to be a bit cautious in those patients, although GLP-1s tend to improve triglyceride levels.
Partly through the weight reduction,
yes. Absolutely. A question about neuroprotection. So again, this is into the future. There have been studies with exenatide and suggestions that the GLP-1s may actually have a benefit both in Alzheimer's, Parkinson's. I'm not so sure about stroke. We saw the data from SUSTAIN where there was a significant reduction in stroke. But there are trials, I think, I'm certainly aware of investigator-led studies looking at neuroprotection. We don't have the evidence yet, but it's an area that's being explored.
And a lot of interest around cognitive decline, etc., and diabetes right now.
And somebody's asking about the impact of GLP-1s on lipids. So we get a reduction in triglyceride, we get a small reduction in cholesterol, and no adverse effects on the lipid profile.
Certainly.
Probably associated with weight
loss
and improved A1C. There's a very UK question around NICE. So I'll just really quickly. So in NICE, recommend GLP-1s around BMI threshold. Do we think that's valid where established cardiovascular disease is present? NICE is about at least 5 years out of date, so it hasn't included any of the cardiovascular outcome trials. So I think it probably isn't appropriate. They're looking at it right now, so let's hope that they update their guidance, but I won't say any more than that. Any theoretical benefit of combining a long-acting GLP-1 with a short-acting GLP-1? Takashi?
I don't think. No.
Okay, so we definitely wouldn't advocate that.
Nor any benefit, and you still see this in practice a lot, of DPP-4s and GLP-1s.
Okay. And then another question about a limit in terms of ejection fraction for the use of GLP-1s. There was some studies, there was a Fight and Live study looking in patients with heart failure where there was some suggestion that there may be concerns, although actually overall the outcomes were fine. And I think in the large cardiovascular outcome studies, while we don't see reductions in heart failure, we don't see any increase. So I'm not aware that there's any guidance about the lower limit of eGFR in which it's safe to use GLP-1s.
And certainly the findings were consistent across the CVOTs in terms of no impact on heart failure, benefit or risk.
But in the case of actually heart failure, as ADA ESD guidance recommends, I prefer SGLT.
Absolutely. And particularly in reduced ejection fraction heart failure. So I think we've had a fantastic discussion. We've covered a lot of ground. I'd like to ask the audience for their patience in answering these last couple of questions, the post-assessment questions. So question one, the same questions we asked you at the beginning. How confident are you describing the most appropriate clinical use and current and emerging GLP-1s? If you could answer that, whether you strongly agree, not sure, disagree, or strongly disagree. Question. So the first one's come through, and we've moved from about 25% confidence to around 2/3 of you being confident, and the third agreeing that you're reasonably confident. So that's really nice to see. So obviously we've had a good discussion, and also about the safety in prescribing, actually even higher now, 3/4 and 25 agreeing that they feel confident. So I'd like to thank my fellow panel for an excellent discussion, and also to you, the audience, for sending in such great and stimulating questions. Thank you very much.
Thank you.
Thank you.
And can I remind you, please, to fill out the evaluation form to get your CME.